And I know, got it. Okay. And I know lots of you are joining from afar. It's an honor and privilege for me to be here. And thank you for the invitation to speak today. It's always very humbling experience for me when I get to share this data set and my life's work with colleagues and friends. And it's great to see old friends and hopefully make some new ones, even though Dr. Bjormison is not here. I wish you were here, George, because this is a story of you and I and our careers as we've matured and together. But let me move forward here. No, I'm kind of controlling a couple different computer screens here. So just one second. Oh, maybe I need to click on here. There we go. So disclosures. I like to say that I'm for the patient, and I'm naturally therefore conflicted with all companies that have something to do in the development of therapies for kidney cancer. I want to work with them, partner with them, and help guide them. And so you see numerous companies that we recognize have stakeholders in the management of kidney cancer. I've been asked today to simply talk about a few items. Adjuvant therapy for high-risk clear cell RCC. There is only one good adjuvant therapy. We have two approved with sunitinib, but we have one, what I call staple for adjuvant therapy. I want to review that data with you. It has been updated recently at recent meetings this year. So give you some comfort as you prescribe that and give you some of my insights. I also wanted to provide an update on therapy for metastatic RCC. We don't really have the privilege of being able to go through all of the therapies in detail, but I want to harm a couple of them, particularly the IO regimen, and choosing an IO TKI, actually the one that was the most recently approved for you all in your country, which was Len-Pembro. And I provided the update at this past ASCO, so we'll kind of run through that. Talk about novel immunotherapy and TKIs, just a brief there. There's several in development, but I want to give you a little flavor there of where we're going, and then what I call a path forward. So renal cell carcinoma has really become, not only has it been my story and Dr. Bjormison's story, it's a story of our life. It's really become the story of two Nobel Prizes in the United States, our new, soon to be officially announced National Cancer Institute director. And let's unpack that here for you. Really, the advances did not happen overnight in kidney cancer, but if you're not an aficionado in the field and you don't do kidney cancer for a living, it may have seemed that way. They've actually 20 years in the making with both clinical and scientific advances. First, the VHL gene was discovered in 1993, cloned, and the biology of the VHL protein was described. We know that if you have somatic mutations in VHL, short arm of chromosome 3, that results in that rare VHL syndrome. If you acquire a mutation sporadically in VHL, you develop uniformly the clear cell histology. Bob Figlin, if you recognize that name, who was at UCLA, and I at the time, we published data that virtually all patients with sporadic clear cell RCC can be detected to have VHL mutations. Second big thing around the turn of the millennium was the classification of RCC histology based on biology. No longer was it appropriate for pathologists to simply put on the path report that they have renal cell carcinoma. Patients need to be further defined into the subtype of renal cell. And we know that these have clear genetic abnormalities and that are associated with their own natural histories and prognoses. Unfortunately, as I stand here today, we have very few new therapies for the non-clear cell histologies, but the future may change there. And then we discovered prognostic factors for patients with metastases. And this is where Canada jumps up and says, yay, Danny Hang and the IMDC. But, it actually started with our good friend Bob Mocher with what we called the memorial criteria, the Mocher criteria. When I was at the Cleveland Clinic just leaving, they're back circa 2003. We validated and extended his criteria. And then subsequent work, I know Danny Hang did some training at the Cleveland Clinic and has formed that international consortium. And we use the IMDC criteria. And Danny is such a humble guy. He would cringe if he knew I was calling it the Hang criteria. But that's essentially what it is. And we've entered now the new treatment paradigm based on the biology of RCC, where we have targeted agents and we are in search for the never-ending search for biomarkers for this cancer. Some wise folks back in 2011 published Hallmarks of Cancer. And I pointed here, they were supposed to be blue, but I guess that was back in Dallas. They've somehow changed to green. as I crossed into Canada here. But these green arrows point to where I think we've targeted these hallmarks of cancer and kidney cancer. Well, with anti-CTLA-4, that was just the beginning of the immune story. Checkpoint inhibitors in general, we certainly do that. Inhibitors of VEGF signaling, obviously we do that. And then aerobic glycolysis inhibitors, and when I mean things like mTOR inhibitors. So we've targeted those three pathways, but there's many other things that need to happen in kidney cancer and many other potential roles for that. This brings us to the discovery of the VHL gene, which I already alluded to in 1993, and the subsequent understanding of its role in the normal cell, and when mutated, its ability to drive growth and angiogenesis. And that launched big pharma's interest in the development of new VEGF agents, and also resulted in the award of the Nobel Prize in 2009. Many of you recognize that. Bill Kalin, a good friend, Dana-Farber, worked very closely with him in that group in developing these therapies. And with that, VHL, both somatic and sporadic mutations result ultimately in the accumulation of HIF, hypoxia-inducing factor, and then downstream the transcription of pro-growth and pro-angiogenic factors, such as VEGF, PDGF, among others. This resulted in an initial generation of VEGF TKIs, what I call the first generation, sunitinib, pazopanib, sorafenib, and axitinib, with, when used sequentially, we had the ability to prolong life 2 to 3 times longer than what we did with interferon. So interferon, if you remember, the median survival was roughly about 12 to 14 months, and we had patients pushing 36 or more months when we would use these sequentially. And then now we have a new generation, and I like to refer to that as the second generation of therapies with multi-targeted VEGF inhibitors, cabozantinib and lenvatinib, which not only target VEGF, and I think, based on what I've already shared with you and your own understanding, we want to continue to inhibit VEGF, right? That's involved with the pathogenesis of the disease, but also we now are targeting things that we have discovered are angiogenic escape or resistance pathways. And we have research that have shown that c-Met and AXL and fibroblast growth factor are all important in angiogenic escape. And so we now have the ability to target resistance pathways with them. Okay, let's go here and here. So the second generation of drug development, which started after 2010, also witnessed one of the greatest advances in immunotherapy with the development of CTLA-4, PD-1, PD-L1 inhibitors, among others. And Jim Allison, who I think you'll recognize here from MD Anderson Cancer Center, was awarded the Nobel Prize for his work. And checkpoint inhibitor therapy became a staple for over 50% of all solid tumor cancers. And in the case of melanoma and renal cell carcinoma, both being studied early, had reaped immediate benefits from the incorporation into our treatment algorithms. And it wasn't long before research into mechanisms by which VEGF receptors, which remember, we should be utilized to suppress the HIF-induced production of VEGF, and the result of the mutations in VHL could rationally be combined with checkpoint inhibitors with hopes of additive or synergistic effects. Here we go. Indeed, VEGF has immunosuppressive effects. Therefore, targeting and inhibiting VEGF would make sense if one was hoping to modulate an immune response. So a lot of us critique oncologists, especially out of other medical disciplines, because they say we just throw things together without rational design. And I'm here to say that the development of kidney cancer therapies has indeed been rational. And I want to share this with you. So research evaluating first-generation VEGF inhibitors like sunitinib and the monoclonal antibody bevacizumab revealed that they could indeed augment and increase T-cell infiltration into renal tumors, clearly embraced as being true scientifically. And also, these same inhibitors of VEGF could make the tumor microenvironment more permissive to checkpoint inhibitors. Shown here is increased PD-L1 expression on RCC tumor cells. And remember, we have shown that increased PD-L1 tumor expression has been shown in not just kidney cancer, but many types of cancers to be the necessary ingredient to successful use of checkpoint inhibitors. The higher the PD-L1 expression in tumors, the higher the benefit of using checkpoint inhibitor. And so a rationale for combining VEGF inhibitors and checkpoint inhibitors was made for treating metastatic renal cell carcinoma. The theory simply goes like this: VEGF inhibitors work by inhibiting tumor growth through blocking angiogenesis, as well as work to augment the immune response through T-cell trafficking, and also augment checkpoint inhibitors activity through increased PD-L1 expression. And that's the theory. Where's the proof? The proof is in the pivotal phase 3 clinical trials that we've all been witness to. And we see this rapid development of drug therapy. And pharma, as pharma goes, it didn't take a lot for them to invest in the clinical development. I must state, however, that not all VEGF TKIs were combinable. And early phase trials, some of which you may have participated in, resulted in significant toxicity and deaths for some combinations. So things like, for instance, sunitinib and pazopanib combined with checkpoint inhibitors were uniformly toxic and should not have been done. And what you see on the timeline here are those combinations that were successful that have resulted in regulatory approval in the United States and now throughout the country of being therapies that were both efficacious and tolerable. Surprising to some was that most combinable TKIs were the second generation TKIs, ones that had gotten kind of a story with them of having more toxicity. And therefore, since it's really the second generation TKIs that have been the combinable ones, all of the first generation TKIs and mTOR inhibitors got pushed to later line of therapy. And now if you have access to all of the available therapies are hardly ever used. So in the United States, the first generation TKIs and mTOR inhibitors have really been reserved to 5th, 6th line settings. This timeline also reveals to us the difficulty that we faced. We somewhat had an embarrassment of riches. The development of new therapies was outpacing the ability of us understanding how to utilize them optimally. And I mean, not at big centers like here, not with your aRCC experts in Canada, not in my practice where I see 200 plus kidney cancer patients a year, but in the Ma and Pa, the community oncologist practice where they see 1 to 2 patients per year. The ability for them, when your drugs are getting 2 or 3 of them approved a year, trying to understand how to utilize them to get the best efficacy, how to handle toxicity was very difficult. And this remains a challenge for us even today, and is the reason why we have such strong educational campaigns where we try to educate the community oncologists and how to optimize therapy and to choose these therapies directly. So let me just start off, and the first topic was really to talk into adjuvant therapy for kidney cancer. This was a double phase trial. It was placebo-controlled trial. I'm not sure if you all participated in it here, but I certainly did. And the placebo arm was indeed a saline infusion. Patients with histologically confirmed clear cell RCC that had nephrectomy within 12 weeks. So this is a key point. You need to start this therapy within 12 weeks of completing surgery. No prior systemic therapy, had tissue available for PD-L1 assessment, but that was not a requirement. Were randomized 1-to-1 to receive the pembrolizumab every 3 weeks for 1 year. That is 17 infusions versus the placebo. Stratifications were based on the presence or absence of M1 disease. The M1 had to be surgically made NED, or M0, which was stratified based upon ECOG performance status in US versus non-US. Primary endpoint was disease-free survival by investigator. Key secondary endpoint was overall survival. Other secondary endpoints were safety. Just show of hands. Do you guys have adjuvant pembro as a therapy here? Good. Okay, this is the eligible patients here. And I have the box here that's really looking at the UISS, which is the UCLA integrated staging system. I'm not sure which staging system you use. It depends on what you're a nephrologist, but there's a variety of them available, including the Catan nomogram, which is the simplest, and I use it in my practice. But anyway, using the UCLA system here, you can see that this included a large population risk. And I would argue that this was why some of the other trials didn't do so well, is that their populations were so heterogeneous. You had people with 80% disease-free survival rates combined on a trial with 20% 3-year disease-free survival rates. So you can imagine with such a variety and such a difference in the risk of recurrence that depending on the number in each of those groups could sway your results. And so if people always will ask, well, why are the other checkpoint inhibitor trials negative? I usually point them to the difference in enrollment, in that for whatever Keynote trial got it right, they had just enough of the patients in the highest risk groups to drive the benefit. And so when we look at who are we actually using this therapy on in patients, this is what I utilize when I risk stratify my own patients. I'm less likely to use the therapy in an 80% 5-year disease-free survival patient. And I'm absolutely going to encourage and use it in patients that are M1 NED because they're going to get the greatest benefit. And what we see, and I'm sorry, this DFS consistent overshows the slide here, but the primary endpoint in the intent to treat disease-free survival at the 24.1 month original publication, and then in the subsequent follow-up at 30.1 months, clearly shows benefit with an actual improvement in hazard ratio to 0.63 and nominal p-value shown there. So in the intent to treat population, which includes all of those patients, there is a benefit. But we know that when we separate it out, which again was pre-specified in the trial design, that we actually see that not all groups benefit the same. And it is indeed the M1 NED that does the best. And so look at that. I would say it's almost malpractice. Yes, I'm saying that here because I'm from Texas. You know, we say boisterous things, but that it would be malpractice not to offer that to a patient and not to give that to a patient if they were otherwise a candidate to receive a checkpoint inhibitor. It's just too great of a benefit with a hazard ratio of 0.28. The high-risk group, which are going to be those T3, T4s, those IVC thrombus candidates, they need to get it too. Where I think we have a little bit of debate, and all the data would suggest you could certainly use them, and you may have your own way you practice, and this is where you have to individualize the way you care. The ITT and the individual data would support use even in the 80% risk group. This is where you yourself and your patient have to make that defined decision based on the side effects, because we know not all patients make it through checkpoint inhibitor without side effects. And those rare patients that have life-threatening complications, it would be tough for me to sleep at night if they were an 80% surviving group. I would feel like I've just ruined them. So I think you need to have that discussion. But the bulk of patients that are at risk should receive a checkpoint inhibitor. And it's awesome that we now have that ability to do that. And we can share, I guess, through questions and answers, how you stratify these patients in your own practice. Do you offer it to everyone, or do you offer it to the highest risk group? And then finally, 30-month overall survival. We're finally seeing the survival curves separate here, and they are separating. We have a hazard ratio of 0.52. The median overall survival has not reached that 30 months, and I expect further reports on survival impact of this as we go forward. When it comes to side effects, again, this is the way we look at, this is the treatment population updated analysis. Shown on the right-hand slide is kind of that usual kind of time course, and this just reminds us that side effects generally occur after several cycles, but I think all of us who have used this therapy recognize that some patients can develop them right away after just one dose. But you have to remember, even after you stop therapy, patients are still prone to have a potentially effect. And then the side effects share in this kind of tornado graph here. And what you're looking at is grade 1 to 2 in the green and grade 3 to 4 in the kind of pinkish color is shown there. And you see a whole host of different side effects that we've come to recognize as immune-mediated toxicities. The elephant in the room is truly this, and this goes back to that discussion, is the 80% disease-free survival patient, someone that you want to play with potential toxicities, and that's a discussion that you have with them. But you can, 1 in 5 patients can have chronic adverse events, 1 to 5% of patients can have severe immune-related adverse events. But thankfully, the bulk of patients have minimal side effects, and I think you'd all agree, this is somewhat like water. It is somewhat like holy water for some patients. They take it, they have minimal toxicity, they're able to achieve that kind of benefit on their disease-free recurrence and do well with it. And then, I think really what drives the point home, and I'm so glad that we've started to incorporate this, and I know the folks in Calgary are doing a lot of this type of research on health-related quality of life and endpoints, that patients actually seem to do better and do well, and they're maintained just as much, very similar if they were on placebo. And so that tells us, although there are some side effects, the side effect impact on patients that otherwise are cured potentially and are living their lives is small when they receive adjuvant therapy. Because certainly if it wasn't, we would question that. And I bet if we showed sunitinib here, we would see a much bigger impact on quality of life. And so this is the March 2023 update to our NCCN guidelines. I know you have something similar that you use, and it's clearly recommended that for patients with clear cell histology, and this is clear cell only, remember, this has not been shown to be beneficial in patients with non-clear cell histology, that adjuvant pembrolizumab should be considered an option for them versus surveillance. And then I'm not sure that adjuvant sunitinib really has a role, and it's given a category 3 to recommend that. Now, as I move into kind of the first line, I wanted to start off with a question here, just to kind of wet our palates here. So this is a 68-year-old male presenting with right hip and leg pain, had it for a month. MRI showed 6-centimeter mass in the right acetabulum. CT scans show the 6.3 centimeter right renal mass, sub-centimeter lung nodules, and bone metastases. I wonder if that means that something happened. Okay. The pertinent history, non-smoker, no autoimmune history, pretty good physical exam. Bone biopsy was pathology consistent with clear cell RCC. And our question is here, what are we going to offer this patient? And I don't really have a way for you to vote, but we can maybe do show of hands for the people in the audience. Pembro-Axi? Hands. No one. Good. Pembro-Len? 2 hands. Mine. Okay. Nivo-Cabo? Okay, that's good. How about Ipi-Nivo? Okay, so it's Ipi-Nivo, or and my job today is to show you some information about Pembro-Lenvatinib and hopefully convince you to realm into that as a treatment option. If we go into our January 2024 guidelines, so they're right hot off the press, you can see that really it's dealer's choice. And really in a court of law, you could make a case, the category 1 for any of these options here. Cabozantinib is the only single agent that's given a preferred regimen because of the Cabo-Sun trial. If you remember that phase 2 trial that resulted in its regulatory extension into the first line intermediate poor risk clear cell RCC pace. And that is actually one of the regimens. That's what I would use if I was going to be using a single agent TKI. But just like we said for adjuvant therapy and M1 NEDs, it's almost would be considered malpractice not to offer a checkpoint inhibitor as a standard baseline therapy for patients that otherwise were candidates for it. Now, I know that we can have conversations about unique patients that present with small volume disease. Is there a group of patients that could be monitored? There are, but those are rare. I mean, I think the default is you're treating with checkpoint inhibitor therapy, whether it be an IO-IO or an IO-TKI in all patients that are otherwise fit for it. And then you make the individual decisions based on the uniqueness of the patient sitting in front of you. And if we go into the non-clear cell histologies, we're seeing some of these play out. We know that cabozantinib now has a preferred recommendation, but we also see some of our second generation. I myself have been involved in the Len-Ev phase 2 trial showing significant degrees of benefit in chromophobe cancer and others, but we also show that single agent Nivo-Cabo, and Pembro have shown benefit. Sunitinib has been very poor outcomes. I think the MD Anderson group with sunitinib and sorafenib shown a 5 to 7% response rate in that group. So it's generally, it's going to be one of these second generation agents that we'd want to consider for our non-clear cell histologies. This is our slide that we spend a lot of time trying to compare apples and oranges here. And this really is apples and oranges. Okay. You've got, first off, not to pick on Checkmate 214 too much, but Checkmate 214, sure, it was the first phase 3 trial, the first approval of immune therapy in the frontline setting for us. It was really only beneficial, no matter how you slice and dice it, in the intermediate and poor risk group. And you don't see included in any of these analysis the favorable risk group. And you could say, well, that's okay because its approval is intermediate poor. That's true, but the clinical trial did include a favorable risk group. And we've seen that published, and we've shown how devastating that favorable group does. Although there may be a survival impact, the PFS is horrible. Sunitinib destroyed it in PFS. And if you added that data into this data set and compared it to these other 3, which have favorable, intermediate, and poor, you would see a difference. So again, just keep that in mind that you're comparing intermediate poor risk group only in the Ipi-Nivo to the other agents, which are favorable, intermediate, and poor. And we do see some, I'll make some generalizable, hopefully fair statements that are not biased. The overall survival hazard ratios seem to be, we'll just say they're very similar among the agents, and they've generally stood the test of time. And you see the most recent updates, 0.79 with Len-Pembro and the 0.84 from Brian Rinne's presentation at ASCO this year. The landmark overall survivals look very similar. The PFS hazard ratios, however, differ, and PFS showing less benefit to the IO-IO. And people would say, well, we talked about that at the beginning. We said that IO-IOs probably don't have a profound effect on PFS. We're lucky we even have a benefit. Okay, we'll buy that. The PFS benefits are predominantly in the IO-TKIs, of which the Len-Pembro has the greatest numeric benefit. Of response rate benefits, again, Checkmate 214, the IO-IO it's not a regimen that you expect to see profound tumor shrinkage that's generalizable. So there's a lot of patients that receive the IO-IO that do not get greater than 30% tumor shrinkage, but that's different. The IO-TKIs have significant impact on tumor shrinkage. And then when we look at complete response rates, we'll say, okay, fairly similar. Outlier, Len-Pembro, standing the test of time, having greater And then the follow-ups are different. The median follow-ups, we now have 4 months of follow-up with Len-Pembro. We have 5 years follow-up with Axi-Pembro. Checkmate Niner, Cabo-Nivo is not going to have any additional follow-up, so it's always going to be the short man on the totem pole at 44 months, and we see 68 months. So there is greater follow-up with the Ipi-Nivo, which is one of the defenses. Sorry. Okay. And the progressive disease rate is where we really stand. So at best, the primary progressive disease rate is 18%. Some people say it's as high as 20 to 30%. So those are patients that you get your scan after your lead-in of Ipi-Nivo, and your first scan is not a good outcome. It's either stable disease, but stable disease with really some degree of progression. Because remember, you can have up to what, 30% tumor growth and be or 20%, up to 20% tumor growth and be progressive disease with it. And so that's a risk for patients. So they can take that, and their first scan shows no benefit. Versus the IO-TKIs, especially like a Len-Pembro, where you have 95% of patients having at least stable disease and 5% with tumor growth. And the IO-TKIs in general, you're in the mid 80s to 90% range. So if you're trying to choose a therapy for a patient that needs a response and they're symptomatic, it's hard to choose an IO-IO because you're playing a risk that they're going to be in that population that may not have a benefit. And so some of us use that as a distinguishing factor there. And we can talk more about that in questions and answers. So are there differences between these trials? Yes, but this is numerically what you've got. Okay. Are there differences in the populations that were favorable, intermediate, and poor in them? Yes. Could that explain some of these differences? Maybe. But again, you'll never know unless there's a head-to-head trial that was compared. We're left with the data that we have. Okay. So checkmate 214 really quickly with here. This is the way it looks. Or this is a median overall survival. And then Ipi-Nivo had not been reached with sunitinib 32.9 months, hazard ratio 0.68. This is PFS. This is the original presentation, PFS by PD-L1 expression. Obviously, if you're less than 1% PD-L1, you tended to do about as good as you did with sunitinib, maybe a little bit more. If you had greater PD-L1 expression, you did better. We know that. We don't use PD-L1 expression to choose therapies in kidney cancer because you generally do better than you would than the control arm. But the PD-L1 expression does enrich for a better response. The minimum 5-year follow-up data here. This is all patients. And what you're seeing is progression-free survivability here, 26.5 versus 5.5 months. And this is overall survival update with minimum 5-year follow-up. And you see now the median overall survival, 48.6 months versus 14.2 months with sunitinib. And this is where we are with second-generation therapy. Remember, we mentioned that interferon, 12 to 14 months median overall survivals with that. It's just a big change. And we should all commend where we've gone with science and taken this for our patient care. And then, probably what's important is that these therapies do actually improve health-related quality of life over sunitinib. So we actually have not only improving efficacy, but patients are generally doing better, living better with better quality of life. Okay, and then I wanted just to share with you, whether or not you've seen this or not, this was, I got to present on behalf of our co-investigators, the final pre-specified overall survival analysis of CLEAR. This is 4-year follow-up of Len-Pembro versus sunitinib. And to remind ourselves, this was a 3-arm trial where the statistics were designed to compare the Len-containing regimens versus sunitinib, not to containing the Len-containing regimens versus each other. It was a 1-to-1-to-1 trial. For the purposes of our discussion, we're going to focus on Len-Pembro, but just remember Len-Ev did beat sunitinib in this trial, but the focus is really on Len-Pembro. And this is the final overall survival analysis that we presented with the landmark at 24 and 36 months shown there. And we see something funky happening towards the end there, but remember that that's low levels. There was crossover, there's post-progression therapy. And we've been able to show that if we look at subsequent anti-cancer medications and try to censor those, although we used a statistical maneuver that was not exactly censoring, it was a replacement maneuver that allowed us to get validity here. You actually see that Len-Pembro indeed does stay throughout the course of the follow-up ahead of sunitinib, has not been reached with an adjusted hazard ratio of 0.55. And if we look at what type of therapy patients got on progression, it was anti-VEGF therapy and PD-1 therapy. So why is this important? Because certainly in countries outside the United States, really everywhere now, there's access to therapies which have shown to impact survival in the 2nd, 3rd, and 4th line setting. Our second generation therapies like cabozantinib, lenvatinib, everolimus, single agent nivolumab have shown survival impacts as refractory therapies. So if you're on sunitinib and first line and you're able to get other therapies that impact survival, then that's going to potentially affect your ability to show overall survival on progression. And that's one of the reasons why these subsequent analysis for anti-cancer medications is important. So I don't think any one of us believe that len-pembro does not impact a survival advantage long-term. And I think this type of maneuver kind of shows us that. And then this is continued PFS benefit of len-pembro with follow-up extended over 23 months. Again, the robustness of the data is maintained with longer follow-up, and that's what we hope to see. This is by IMDC risk group. So this should give you a comfort. So no longer do you have to sit there and do your IMDC risk for favorable, intermediate, poor. I know a lot of us have medical records that require us to check boxes. Mine does, but you don't have to. You can just, for a community oncologist, they don't have to remember all those details. They can just choose len-pembro in everyone. They don't need to worry, is it an intermediate, is it a favorable risk person where IO is not good? And you can see here the benefit exists in the favorable, intermediate, and poor risk groups. Objective response rates per independent review, 71.3% maintained over, it's more than a double benefit in objective tumor response rate. And in this, you can actually look at best overall response and break it down here. CR rate 18.3%. The PR rate with greater than 50 to less than 75% was 23.7%. PR with greater than 75% reduction, 16.6%, and PRs with greater than or equal to 30%, 12.7%. So the PRs are profound PRs. These are not mild PRs. These are significant PRs with the majority of folks having greater than 50% tumor reduction. And then you see the stable disease rate, leaving a progressive disease rate of 5.4%. If we break this down and try to marry into the response and survival, they marry. So patients that have the greatest tumor responses tend to have the greatest chances of survival. And you see overall survival has not been reached in the CR group or the PR with greater than or equal to 75% risk reduction. And it has been met in those other groups shown there. And this was our overall survival. Really, the take-home point was and this was the take-home point with all the therapies we presented at ASCO this year, that all of the IO-TKIs with further follow-up, the robustness of the data has been maintained. So IO-TKIs have stood the test of time and should be considered comparable options to an IO regimen with distinct advantage of being able to use in favorable, intermediate, and poor, being able to use with greater CR rates and less progressive disease than an IO. So what are the next steps for frontline? I think there's a lot of us have thought about, triplet therapy, and we've seen some of the negative results of that with excess toxicity without a lot of gain. Certainly there's a financial toxicity. We're now getting regimens that are going to be $45,000 per month without a significant gain in outcome benefit. And we saw the results as Tony Choueiri presented from Cosmic 313. We have an ongoing Merck study, which is actually using one of our hope to be new agents for all comers and clear cell RCC, but has been approved for von Hippel-Lindau syndrome, which is belzutifan, and its role in combining belzutifan with a len-pembro type of regimen. That trial's ongoing. So this idea of triplet regimens has not been completely put to rest, but I think we have a high bar where we want to see that the added third benefit really pushes efficacy to a level that's worth it when it comes to side effects and the financial toxicity. Pedigree is one example of an adaptive trial where they're looking at patients, for instance, that got ipi-nivo. And remember, we said the big hallmark for ipi-nivo is that there's a 70% of patients that may not have ideal response at that first CT scan. What do you do with them? Do you just keep them going with stable disease, or do you potentially add in cabo and do you salvage them with cabo? And so this trial is going on, and we'll see what the results are of can you bring in an VEGF TKI to salvage the benefits. And we know what happens when you bring in cabo at the beginning, you get greater PFS and response rate. So why is this important? Because you could say, Dr. Hutson, why do we need to do this? Let's just sequentially use our agents. Why are we messing about adding everything first? Well, the reason is something like this, that we lose patients. And I've found this is not just in kidney cancer. We have this in bladder cancer too, a problem. And I bet it's with lots of cancers, that there's this attrition of patients as you move from first to second to third to fourth line. So if you're going to save your best therapy to later, your patient may never get there. you lose half of them. So it begs us to utilize our best therapy first. And hopefully by doing so, we can get people out further than what we are. And this drives the rationale, not only for kidney cancer, but now with bladder cancer with enfortumab vedotin and Pembro. Why are we using that? People say, why do we use that first now? Well, it beat Gem-Cis, but why not use it later? Because of that, because patients don't make it to later lines of therapy. And then we're still left with this, and this goes back from our days, and George Bajormison will recognize this slide back from the early days. We've never been able to correlate PFS first line with PFS second line. And I remember back in the day when we had drugs and we were sequencing them, people would say, well, how do you choose? Well, if someone had a good PF with a VEGF inhibitor, I give them a VEGF inhibitor next. Well, that never, Danny Hang's IMDC database never showed that was true. So just because you respond well to one class of agent or one type of agent does not mean you're going to respond well to the second. And so I've had patients where they haven't responded to 3 lines of therapy, and it's the 4th thing I choose that they do well for 3 years with. So, I mean, we still struggle with understanding that. And so for relapse therapy, we've got, we now are, since we said, and we all agree that IO therapy is a staple, patients need to have that as a backbone to therapy unless there's some other reason for them not to. We break down patients to prior IO and patients who have not had IO. So if you've not had IO therapy and you make it into the second line setting, woe are you. You need to get IO therapy right away. And so as our guidelines would suggest, if you've had prior IO therapy, then any of what I call the second generation, aRCC found its way on there, although I think of it as a first generation therapy, but certainly Cabo, Lenev, Tivozanib, and probably soon to be Belzutifan in the United States would be what I think are your next lines of therapy. And you know what? That takes you out to 4th line if you sequentially use those. So is there a role in my mind for sunitinib, pazopanib, sorafenib, everolimus? Not unless I got that unique patient out to 5th line, and those are generally few and far between. Okay, so this is a summary of where we are with our second line therapy options here, and they're shown here. And again, Lenev, I should say if conflicted with all the trials because I was involved with all of them, but Lenev holds a dear heart to me because I started that study when it was back known as E7080. When Bob Mocher called me up and said, Tom, I've got a trial, it's entering phase 1, do this trial with me. And we were amazed to see the benefits of this agent. And it's always awesome to see it in clinical trials and then how it translates out. But that received regulatory approval based upon a phase 2 trial of Lenev versus Len alone or everolimus alone, showing significant benefit. Cabozantinib obviously shown benefit over everolimus as well as nivolumab. And all 3 of these become options for you. Obviously, Nivo, not if you've already used checkpoint inhibitor, but Cabo becomes an option. If you use Cabo Nivo, not an option, is it? Because you already had, and then you end up with Lenev. So a lot of what you're choosing is dictated based upon how you're following up. And I wanted to throw TiVo in here because TiVo has been the only trial that actually had a modern population on the trial. There was a subgroup of patients that had prior IO therapy and a subgroup that had modern TKIs like Cabo and Lenev, and they've gotten, and we know that TiVo can produce benefit in patients over a greater benefit than sorafenib in patients that were treated with more of our modern therapies. And so, again, this is therapy for non-clear cell. As we said, this is how we would approach that for completeness. So where are we going as into novel immunotherapy for renal cell carcinoma? So MEDI572 is a monovalent bispecific antibody. Bispecifics, you may have heard about, they're gaining a lot of traction in a variety of solid tumors. And this gives us the ability to target both PD-1 and CTLA-4 in the same antibody. So this is a humanized IgG1, and the CTLA-4 is the tremelimumab arm. So this study has showing great efficacy in early clinical trials. You can show the waterfall graphs here showing significant efficacy in first-line RCC. And then the different toxicities that we see at the different doses. And the optimal dose for this is still undergoing evaluation. But, there's so much more, and I just picked this one out. The treatment for renal cell is now evolving around TKIs, but also importantly, immune-based strategies. This is a diagram that shows, it's going to be showing familiar and unfamiliar kind of molecular markers for on cells. The ones that are activating are going to be in green, the inactivating are in red. And don't worry, I would only quiz you if George was in the room, but since he's not in the room, because we quiz him on this, you get a pass on this. But there's a lot of markers now, and that's where one of our focus is going to be on how do we overcome resistance to checkpoint inhibitors. And some of the excitement we have now is looking at immunotherapies that overcome some of those resistance mechanisms here. So immune targets include, obviously CTLA-4 in the combination, but they're currently enrolling in our network, the Sarah Cannon Research Network. We have LAG-3, very exciting compound, TIGIT, and other novel cytokines that we're trying to study now, both as single agents and in combination with immune therapy strategies, as well as combination strategies with TKIs. Okay, so I wanted to also talk to you about another TKI, which is in development. This is the XL092. This targets pathways associated with tumor immunosuppression. Some people call this the son of cabozantinib because it is the son of cabozantinib. It's a similar drug. It inhibits MET, AXL, but also MER. And it's being studied internationally in the STELLAR trials. And we saw updates from the STELLAR trial at ESMO, but it's a molecule that has the ability to modulate the immune response too. And so you're going to see it combined. But really, I wanted to kind of, as we get closer to the end here, talk about a compound which I'm not sure is belzutifan approved here. Not okay. So it has an approval in the US for the VHL syndrome because it's a direct HIF1 beta inhibitor, but it's also shown based on a study that was done at ESMO benefit that will likely result in its approval in the refractory setting for kidney cancer and will be added as a second generation. And I really mean generation. So it's a second generation because we have third generation agents entering our clinics. And I'm sure that you probably do too. And so I'm excited about that. But this works through HIF pathway, affects proliferation, survival, metastasis, and angiogenesis. And the excitement was what was presented at ESMO was the LIGHTSPARK-5 trial with belzutifan compared to everolimus. Everolimus became the sorafenib of the modern day. It's the one that we beat up on a lot. And this was unresectable, locally advanced metastatic clear cell, 1 to 3 prior systemic therapies that included at least PD-L1 and VEGF inhibitor and stratified based on IMDC and the number of prior therapies. The primary endpoint was PFS. And if we look here at PFS here, it does something funky. So I had a wager with people that the NCI, the FDA wouldn't approve this and that it's going to go to CTEP. I'm going to see because of what happens. The median is no difference because you see that happen there, but it's really a long-term effect that we see. It's a latent benefit. So the HIF alpha inhibitors have a latent benefit that's profound. Some people say doesn't matter. They're going to see that and they're going to say, yes, this latent effect exists, but I don't know. We'll see whether whether the FDA will have any hiccups because of the median being no difference. And this is the final overall survival where we do see a separation that occurs. But again, we need to follow it further in this study. So a lot of excitement. And I think, when it comes to response rate, there's clearly a significant difference in response rate. We have one person with the CR. We have a PR and stable disease in many folks there. And then when it comes to toxicity, the toxicity of belzutifan puts it in a class by itself. So it's probably the most tolerable of the agents. Anemia is the big thing that you can see with this. You need to monitor. Sometimes it requires blood transfusion, but it actually appears to be as tolerable or less tolerable, or as tolerable or even more tolerable than everolimus, and certainly would give axitinib and tivozanib a run for the money on tolerability. So as far as its combinability, it's become a major player now moving forward. But we're left with, could IO, post-IO be effective? And we've already seen, data presented at this past ASCO that depends on the IO you're using. If you use a PD-L1 like atezolizumab, probably not. Atezolizumab had not shown a survival benefit in kidney cancer. It seems not to do well as the traditional PD-1 inhibitors. So there are trials that will further answer that question for us. And we've got, this cancer immunotherapy cycle just throws us a whole host of different agents. We've got viral therapies that we can bind to. We've got CAR T therapies. There's so many different types of therapies to harness the immune response, all options for us moving forward in kidney cancer. So a path forward, as I end here, RCC is heterogeneous. We know that there's a group of patients that don't respond to anything that we throw at them. We know that there are significantly mutated genes and pathways in clear cell RCC. Some of them are shown here on the right. And it's really Kim Rathmel, who's been selected to be our new National Cancer Institute director. There was a release out on POTUS, naturally through Twitter, that this was going to happen. And so she is a kidney cancer czar. She is a basic scientist, MD, PhD, that spent her life working on kidney cancer. So 2 Nobel Prizes directly related to kidney cancer research, and now our new NCI director kidney cancer doctor. So it just shows you where we've gone in kidney cancer as a scientific development. CCA, CCB represent two distinct groups that she was able to identify. One were angiogenic driven, the other were immunologic driven. And that's from years ago. And we've utilized that as we move forward. And that made a lot of sense to us. This is my time at Cleveland Clinic. This is back in 2000. We recognized then the diversity within RCC with all these different patient outcomes happening with the different therapies. And we know that resistance is universal and that we understand now that clonal selection under certain pressures leave different types of clones. And that becomes significantly important. And I want to end with this slide by James Larkin and the late Martin Gore, where this is from Lancet 2010, where the hope was to turn metastatic RCC into a chronic disease if we cannot cure it. And I think now we have, with CRs happening at greater extent and with new therapies, I think we are getting closer and closer taking it into a chronic disease where the median survivals are 3 to 5 years if we appropriately sequential the use of our currently available therapies. And who would have thought of that at the turn of the millennium? So with that, I'll thank you. And I know I've been about 45 to 50 minutes. So thank you much.
Great.